Troubleshooting in supine PCNL. First of all, we'll start with the problems in position. The first problem we face is overlapping of PCS shadow on the spine, and this happens when we rotate the trunk more. So the trick is a minimal rotation of the trunk. The second issue is with the table sidebars. When a thin patient is brought towards the edge of the table, the sidebars will overlap with the PCS shadow, so they need to be pushed away from the edge. Another problem is the table edge will hamper the downward movement of the scope. The patient needs to be pulled more towards the table edge so that the movement is free. The lithotomy stirrups also hampers for the movement of the scope, especially the downward when we go in from the lower pole. So the patient needs to be pulled up, and now you can see the movement of the scope are free. So the take home message for positioning is the minor shifting of the patient will help with the stirrups and the table edge. Draping. The customized drapes were made for prone PCNL. We can manage without it. A plastic sheet is placed below the flank, one end, and another end is placed into the bucket below. A cloth drape is fixed at 4 points into the table sheet and 2 points onto your gown. This acts as a shelf to keep the objects, guide wires, needles, so that they do not fall down. It also helps to catch all the stone fragments, so at the end they will be collected here. It also helps to collect all the water into the bucket and the water doesn't get splayed too much on the floor. Puncture can be made in a monoplanar, biplanar and USG guidance. Coming to supine monoplanar technique, in which the C-arm is at 0 degree. You can note reaching to electric catheter and doing RGP by urologist is easy in supine PCNL. The ureteric catheter along with the syringe is easily placed on the patient after RGP is done. Then the puncture site is marked. There is no fear in moving up, even if it is going supracostal. Here we are puncturing the upper pole. We are utilizing the downward movement of the kidney during inspiration. A stab incision is made. The needle seems to be going angled up. But when the patient takes deep breath, the kidney moves down and the angle of the needle looks down. 2 attempts, not much movement of the kidney and no water. Third attempt, readjustment of the depth, nice movement of kidney, calyceal indentation and clear water. The guide wire goes in and confirms a successful puncture. Take home message. Experience is needed for adjustment of depth. The movement and calyceal indentation are very much important. Supine biplanar puncture. We start with C-arm at 0 degree and do RGP. The first scenario, the needle is superficial to the target, and when C-arm is rotated 30 degrees cephalad, it moves towards the feet. Now the C-arm is brought back at 0 degree. Second scenario, needle deeper to the target. C-arm movement 30 degree towards cephalad, needle moves towards the head. Now the needle is readjusted to get the kidney movement. Kidney moves, calyceal indentation and puncture. Now the needle stays there and colonic shadow moves down when the C-arm is rotated 30 degrees up, and then colonic shadow moves up again when the C-arm is at 0 degrees. The clear water confirms the puncture, so does the movement of guide wire. The take home message is it's useful for assessment of depth in initial cases. There are troubles with dilatation. The issue is with hypermobile kidney, which moves and rotates with dilatation and puncture and interferes with them. A counter pressure on the abdomen by hand is the troubleshoot. Many are afraid with colon in supine, but the chance of injury is lesser. Observe the differential movement of the colonic gas and the PCS, and observe it again while coming out and colon. Water tends to drag down with the scope and tube are set with gravity onto you and on the floor. A simple hack putting a gauge piece onto the scope helps. Lower pole puncture has its own issues. The hip fat disturbs in going to the upper pole and pelvis sometimes. Straight leg position helps. Upper pole access from lower calyx is mostly needed, and we can access the upper medial calyx. Many times the stone will migrate to upper pole when we do from the pelvis, and that calyx is accessible. But accessing the upper lateral calyx is difficult. So what we can do, we can rotate the patient's trunk and put few taps here. The stone from the upper lateral calyx will fall down. Here we cannot see the stone in upper lateral calyx. The patient trunk was rotated, and then we can see the stone there and can retrieve it. So the take home message is the upper pole is easily accessible from the lower pole. The mid pole is the most friendly calyx for clearing the large burden. When you made enter with the middle pole access, we can clear the pelvis easily. We can go to the lower pole to clear the calyceal stones, and then the upper pole. There is a common thinking that upper pole access in supine is difficult. But when we see the pleura moves up when we move anteriorly on the chest wall. So a puncture in supine is more safer for the pleura. Note the change in location of the upper pole in relation with the ribs. It was supra 12th when viewed from behind, and now it became supra 11th when viewed laterally. It's the upper lateral calyx which we are targeting. The point of access E and C changes to B and D when done in supine in relation to the ribs. The take home message is upper pole access is feasible, and don't be afraid to go supracostal or supra 11th in upper pole access in supine. There has been concerns about nephroscopy and scope maneuverability in supine, but going to the upper pole and going to the pelvis and ureter has not been a concern. It's always better to make one more tract than having a top. PCS getting collapsed is another issue in supine, which leads to limited space and vision. The problem is we keep ampullas very close to the stone, so it gets collapsed. If we pull out the ampulla lightly, we get a better vision and space. There are scenarios in which we find inaccessible calyces from the PCNL tract. We can use the help of ECRIS. Those calyces can be reached and can be cleared. We can also use flexible from the PCNL tract for the same. Sometimes in upper ureteric calculus, the stone slips down after positioning. Supine is very much helpful for those scenarios. You do not push the stone first. What we do is we do a upper or a mid pole puncture first, and then if we can clear, we clear the stone from the anterior tract. If not, a push from below can be done at the same time. The take home message is do a upper or mid pole access first and then push up the stone to avoid it going to an unwanted calyx. If we are not in our familiar arena, a self-help from the table can be done. We can take up the instruments, the dilators directly from the table without the need of assistant. Thank you for your kind listening.